available for you there. So today, yesterday, started yesterday, and we're still having this going on today, the Toronto Cardiac Symposium about tetralogy of Fallot. If you have the chance today, so take a look. There's been a very interesting talk, was an amazing meeting so far, and I'm sure it's going to continue for today being great. And tomorrow, if you had already subscribed, you can't register for this anymore. But if you have already subscribed, you're going to have the host. You're going to be able to practice some tips and tricks on tetralogy of Fallot with a lot of world-recognized experts on surgery, including our dear Sasha. He's one of the proctors of this amazing training course, hands-on. So this is very, very nice. And on Saturday, we are very happy to have a big webinar. And we are, this is going to be the premiere of us having webinars on the weekends. So you can give us your feedback if you like it to be on the weekends, or if you rather this should be on the weekdays. We are going to try on the weekends and see what happens. So continue the Overnovsky series. We are going to talk about the challenges of hypoplastic heart syndrome. Gil prepared amazing things, invited a lot of outstanding speakers. So this is going to be very nice in a very interactive, informal way, the way this Overnovsky series has been. So if you're interested in intensive care and if you're interested in hypoplast, please join us on Saturday. On June the 14th, we are going to have functional single ventricle part 1 with Dr. Silverman. I'm sure this is going to be great. Then July, we have the second part. And for August, we are going to have a little break, and Epstein malformation is going to continue on the next semester. So please join us on June the 14th. And in the end of the month, we are going to have our fetal series is on the June 24th. Sorry for the typo. On the Thursday. I'm sure this is going to be very interesting. We are going to have nice colleagues from Italy to talk about the fetal cardiology. And now with you, we are going to have Dr. Anderson talking about isomerism for this week and next week. I'm sure this is going to be awesome. Now I just have to find the video. This is with me. Just a second.
Well, good afternoon to you all again, ladies and gentlemen. So we're now reaching the final few episodes of this year's Classrooms for the Congenital Heart Academy. So this week and next week, we're going to share with you problems that still exist in the description of what you see on the screen at the moment, isomerism. Now, what you see on the screen at the moment are two structures that are mirror images of each other. And isomerism exists in the chemical field, and here is the definition of what we mean by isomerism. And these, in fact, are enantiomers, and as defined by Wikipedia, which, as you know, these days is the fount of all knowledge, these entities are stereoisomers. And as stated in Wikipedia, they are related to each other by a reflection. And here, key point, they are mirror images of each other. But when we use the concept of isomerism in the setting of physical chemistry, we usually mean separate entities that are mirror images of each other. And we have that in the setting of congenital heart disease, in that the individual with mirror-imaged arrangement is the mirror image of the majority of us that have usual arrangement. And so we are not using the term isomerism to describe that situation where the person who is mirror-imaged is the isomer of the usual person. On the contrary, we can look at a different definition, and I recommend strongly to you this review. It's quite an old one now. You see, it comes from the Korean Circulation Journal. It's by Dr. Kim. I've never met Dr. Kim, but I am impressed by this review that now is 10 years old. And you see, Dr. Kim describes to you the origin of the word. It comes from the Greek, equal parts, and as he says, the structures themselves are mirror imaged. But here is the key. You can read it yourself. Dr. Kim emphasizes when we use isomerism in the setting of congenital heart disease, we are talking the situation in which morphologically right structures or morphologically left structures are found on both sides of the body in the same individual. And this is the key. This is what we want to discuss with you today. Today, we want to establish that such a situation does exist in the setting of a congenitally malformed heart. And then next week, we want to extend from that to show you how best to analyze and describe the cases in which we find such isomerism. So there's no question that isomerism exists in everybody. This is a picture of the dorsal surface of my right hand. And this is the picture of the dorsal surface of my left hand. And in fact, the hands, the right sides of the body, the left sides of the body, and everybody are the exemplars of bodily isomerism. So we all have isomeric structures. The skeletal musculature, the bones of the skeleton in everybody are isomeric. But when we are thinking of isomerism in the setting of congenital disease, we are not talking about the parietal components of the body. We are talking about the organs. And the organs, as you're well aware, are usually lateralized rather than being isomeric. So what we want to discuss with you today is whether such isomerism, as seen in the hands and the parietal parts of the body, can exist within the heart. And if that is the case, we then have to decide which part of the heart is isomeric. As my good friend Richard Van Praag, for quite some time, has suggested that isomerism is no more than a useful mnemonic. We do not think that is the case, but we would like to provide you with the evidence. And what it all comes down to is relating the concept of isomerism to the syndrome, which I'm sure most of you still call visceral heterotaxy. So we can look at this by returning to the review of Dr. Kim, because Dr. Kim has discussed isomerism in the setting of heterotaxy, and here you see he's provided you with a definition of heterotaxy itself. Again, this is a word, it's derived from the Greek, and it means other than the usual arrangement. So, in this setting, anything that is not usual is heterotaxic. Within this literal definition, therefore, individuals that have that mirror image derangement, those who are the mirror image of usual individuals, would themselves be heterotaxic, and the arrangement for the organs in those mirror imaged individuals is not usual, so hence is heterotaxic. But Dr. Kim has gone on to discuss the definition offered by the Nomenclature Working Group. Now, I am part of the Nomenclature Working Group, so I accept some of the responsibility for producing this definition. I would no longer use this definition, but for better or worse, it is there. And as you see, Dr. Kim has summarized the definition admirably for the Nomenclature Working Group. Heterotaxy is the same thing as visceral heterotaxy, heterotaxy syndrome, and it is defined as the abnormality where the internal thoraco-abdominal organs demonstrate abnormal arrangement across the left-right axis of the body. But even within this definition, those individuals that have a mirror-imaged arrangement obviously have an abnormality in arrangement across the left-right axis, so they would still be heterotaxic. But for better or for worse, the working group, as I say, part of the working group in the existing definition has excluded mirror imagery for the setting of heterotaxy. If I had my druthers, as they say in the United States, I would no longer go along with that. But better or worse, let us presume that we are excluding mirror imagery from the context of heterotaxy. We then know there are two subsets of patients to be found within heterotaxy. And this is where isomerism becomes so important. Because I believe it is key. We have to determine how best to segregate and describe these two subsets of patients, because if we do not, we will never resolve the genetic background of these lesions. And I'll get onto that very shortly. So if we're going to discuss isomerism against heterotaxy, we have to concentrate upon the heart. We have to ask the question, can the heart exhibit isomerism? And already we can get pointers of the fact that it does exist by considering the way in which it develops. Now, I've shown you this picture before. It was produced by my colleagues from Amsterdam, and it demonstrates the notion of ballooning of those components of the atrial chambers that eventually give the chambers their specificity. So I mentioned the atrial chambers, and there you see ballooning from the atrial component of the developing heart tube, we have the right and left atrial appendages. The Amsterdam group also showed that we have ballooning, the apical part of the left ventricle, from the inlet part of the ventricular loop. And we have ballooning of the apical component of the right ventricle from the outlet component of the ventricular loop. Now, there is a key difference here that is directly related to the concept of isomerism. Because what you see is that the atrial appendages balloon in parallel to the atrial component of the developing heart tube, whereas the ventricles balloon in series from the ventricular loop. And that is key to the understanding of what in the heart is isomeric. So we then need to ask the question, what is it that gives the chambers of the developing heart their morphological rightness as opposed to their morphological leftness? And we know now that this is under control of what we call the laterality genes. And there are two families of genes that are critically important. The one is the PITX2 family, which includes sighted, and these genes produce morphologically leftness. And these are the dominant genes. And it is under the influence of these genes the developing embryo becomes morphologically left. Now, because these genes are the dominant genes, something has to stop them reaching the right half of the body, else everything would become morphologically left. And we know that there are a second family of genes, several within it. I've named here two of them, FT1, nodal. Another one is sonic hedgehog. And we know that these genes, during normal development, create a midline barrier, and they confine the PITX family to the left side of the developing embryo. So it is because of the presence of this midline barrier that the left half of the embryo achieves its morphological leftness. PITX2 and and the other PITX genes cited do not reach the right side of the body, so the right side of the body then develops morphologically rightness. So we can put this into the context of the developing heart when we have a straight heart tube. This is a scanning electron micrograph, developing mouse heart made by my good friend and colleague Nigel Brown. And this is at the stage where the heart is beginning to loop, but has not quite looped. And at this stage, the heart tube is more or less straight, and so it has a left side, that will respond to the morphologically left genes. It has a right side, and that will not respond to PITX2 and the other genes in that family, because the midline barrier will stop those genes reaching the right side of the developing embryo. But look what happens subsequent to ventricular looping. Because subsequent to ventricular looping, a significant difference has developed between the atrial components and the ventricular components. We still have the atrial component having a right side and having a left side. And so the appendage that balloons from the left side of this part will respond to PITX2. The appendage that is ballooning from the right side will not respond to PITX2 because the midline barrier will stop the gene getting across. And so we will have a difference in the atrial appendages. But that is not true for the ventricles, because the morphologically left ventricle will have a left side and will have a right side. The morphologically right ventricle will have its own left side and right side. So the ventricles will respond in comparable fashion to the laterality genes, even when those genes are abnormal. And that is why, when we look in the heart, we find evidence of isomerism in the atrial chambers, but not in the ventricular chambers. And that is why, eventually in the mouse, we see that the morphologically right atrium develops broad junction with the smooth-walled component of the atrium, the pectinate muscles extending all the way around to the crux of the heart, whereas in the mouse, the left appendage has a very narrow junction with the smooth-walled component of the atrium, the pectinate muscles confined within it. And as we're going to see, what happens in the mouse also the human. But we can take it one step further in the mouse. So we've said that PITX2 produces morphological leftness. Well, the clever molecular biologists have knocked out the gene for morphologically leftness. And this is one of the mice, the colony of mice prepared by Dr. Jim Martin, who works in the University of Texas in Houston. He collaborated with Nigel Brown. This is another of Nigel's scanning electron micrographs. And you are looking at the undersurface of the atrial chambers of the mouse heart in which PITX2 has been knocked out. Unequivocally, I suggest to you that both sides of the atrial component of the heart are indeed mirror images of each other. We have bilateral, morphologically right appendages. We have right isomerism. And this is another heart that was developed by Dr. Maino in Japan, and Dr. Maino was very kind to share these images with me. This is a heart in which Dr. Maino knocked out left U1, and as you know, left U1 creates the midline barrier. So now PITX2, the gene responsible for producing morphological leftness, can extend all the way over and can influence the right side as well as the left side of the developing heart. And here, I hope you will agree, we have appendages now that are mirror images of each other, but now they are tubular, they have a narrow junction with the central part of the atrial chambers, bilateral morphologically left appendages. By knocking out the midline genes, we have produced left isomerism. So we know now from this evidence from molecular biology that the heart can exhibit isomerism. It is much more than a useful mnemonic. That's all very well, of course, in developing mouse heart, but can we recognize the isomeric features in the postnatal human heart? Equally important, which of those features are isomeric? So I've shown you already that it is the atrial chambers that show the features of isomerism. So the question we now have to ask is, can we distinguish rightness from leftness within the atrial chambers? And now we have a perfect way of doing that. It is the principle that is called the morphological method. To remind you, the morphological method states that we should identify structures on the basis of their most constant part. And I should remind you again that this principle was developed by Richard van Praagh when, in 1980, he was criticizing a paper that my colleagues and I had written on what we wanted to call the univentricular heart of right ventricular type. And Dr. van Praagh was 100% correct with his criticism, and he established the morphological method on that basis, saying we should not use one feature that is itself variable to define another variable feature. As you will see, this works equally well when we look at the atrial chambers. But if we're going to know which is the most constant atrial component, we need to know how many components there are in the atrial chambers. You see, I've kicked off with the body. Now, the body may be a new concept to you, although we have discussed it before. It is that part of the heart tube from which the appendages balloon, the rest of the atrial chambers come together and unite upon the body, but it is not well recognized. But there is a body within both atrial chambers. Perhaps the most obvious feature is the venous connections. But as we will see, as we have learned from Dr. van Praagh, we should not necessarily use those features that are themselves variable. Another feature, the vestibule. What is the vestibule? That is the part of the atrioventricular canal that becomes incorporated into the atrial chambers. The septum, of course, is key in distinguishing the atrial chambers, but you are all well aware that one of the malformations is septal defects. So almost by definition, we're not going to be able to use septal structures to define the difference between the chambers. So then we come to the final part, the appendage. So let's look at these parts, how they exist within the normal heart. So now Diane is going to illustrate to these components of the heart in the morphologically right and left atrial chambers.
The morphologic method allows us to identify structures on the basis of their most constant parts. And we're going to look at both of our atriums for their constant morphologic features or characteristics. And both normal atrial chambers have a body, a venous component, a vestibule, a septum, and an appendage. On the right, our appendage has a blunt or triangular tip and a very broad junction with the venous component. Many people think that just this triangular tip is what makes up the right atrial appendage, when in reality, it is this entire anterior aspect. And when I fold this anterior aspect back along this broad junction, we'll see that there is a prominent muscle, which is the terminal crest. And from the terminal crest, we see the pectinate muscles extending along the entire anterior aspect of the right atrial appendage. Within the right atrium, the venous component is this smooth-walled area between where the superior cable vein joins the right atrial roof and the inferior cable vein, its floor. The septum is marked by the flap valve at the floor of the oval fossa and the anterior-inferior muscular buttress. On the right, the body of the atrium is quite a small, nondescript region that is or lies between the inferior aspect of the oval fossa and the area where the inferior cable vein joins the right atrium. So that in this area, you might see some fenestrations because this is where the left venous valve resorbs during development. The vestibule within the right atrium is this smooth circumferential region that lies between the distal extent of the pectinate muscles and the hinge point of the atrioventricular valve. And it's an important point to make that the pectinate muscles that encircle our right atrioventricular junction separate the smooth-walled vestibule from the smooth-walled venous component. The morphologically right atrium is identified by the extent of the pectinate muscles around the right atrioventricular junction to the crux of the heart. So here's the position of where the coronary sinus is entering or joining the right atrium. Our morphologically right atrium is the pectinated appendage, has a broad junction with the venous component and a triangular or blunt tip. On the left, the pulmonary veins join the roof of the left atrium or the posterior aspect of the left atrium. The appendage is typically tubular with often some scallops along its edge. The appendage has a narrow junction with the venous component as opposed to that broad junction that we see on the right. There is no terminal crest on the or within the left atrium, and the pectinate muscles are confined to the appendage. So there we see the narrow junction of the appendage within the left atrium. The body of the left atrium is larger than the body that we see within the right atrium, and it is the site of union of the appendage, the atrial vestibule, and the septum, so that the body of the left atrium is smooth along with the vestibule. And on the left, the pectinate muscles do not interpose between the appendage and the body, so that we have this smooth surface throughout the entire left atrium. So our vestibule on the left is smooth along with the body, and the pectinate muscles are confined to the atrial appendage, which has a very narrow junction with the left atrium. The coronary sinus lies within the left atrioventricular groove, and it is a morphologic left-sided structure. When the left sinus horn diminishes during development, it has walls that remain separate from the wall of the left atrium, and it gets incorporated into the left side of the atrioventricular junction and becomes the coronary sinus. Just as a nice confirmation of the differences between the morphologically right and morphologically left atriums, I have a short axis view here where I've removed the majority of the arterial trunks and the atrial chambers. So here's our pulmonary trunk, the aorta deeply wedged between the two atrioventricular valves. And you can see nicely on the right that a morphologically right atrial appendage is our pectinated appendage with the pectinate muscles extending around the atrioventricular junction to the crux of the heart. The thin segment of right atrial vestibule lies between the distal extent of the pectinate muscles and the hinge point of the tricuspid valve. The left atrial appendage is tubular with a narrow junction to the venous component, and the pectinate muscles are confined to the appendage. So here we have the entirely smooth left atrial vestibule. This view shows us nicely the differences between our pectinated morphologically right atrial appendage and our smooth left atrial vestibule with the narrow junction of the appendage and the pectinates confined to the appendage. The coronary sinus, as we know, drains into the right atrium, but it is a left-sided structure. As the left sinus horn diminishes, secondary to the venous shift towards the developing right atrial side, the walls of the sinus horn remain separate from the walls of the left atrium, and the walls of the sinus horn then become incorporated into the left half of the developing atrioventricular junction and become the coronary sinus.
So of those components, I can tell you that it is the appendage that is the most constant part. We know that because you will all be well aware, totally anomalous pulmonary venous connection is a well-recognized malformation that rules out use of pulmonary veins. The vestibules are not always there when we have atrioventricular valvar atresia. The septum can be deficient. The body is very difficult to recognize. It is present. It's not always in the same place. So the appendage is the most constant component. And what you've already seen in what Diane has shown you already is that it is the pectinate muscles that distinguish the appendage wall from the remainder of the atrial walls. But what we now want to emphasize again is that the key feature for distinguishing rightness versus leftness is the extent of those pectinate muscles, specifically the extent relative to the vestibule. Because when we assess it in this fashion, it is also the most obvious feature. So Diane's going to show you that heart again, and now she's going to emphasize this feature, the extent of the pectinate muscles relative to vestibules.
We know that the atriums are morphologically identified by their appendage and the extent of the pectinate muscles. And here we see nicely that the pectinate muscles are surrounding the right atrioventricular junction and extend to the crooks of the heart. The right atrial vestibule is a smooth structure with the distinguishing feature on the right being that the pectinate muscles extend around the vestibule and interpose between it and the smooth-walled venous component. And the vestibule extends from the distal extent of the pectinate muscles to the hinge point of the atrioventricular valve. If you remember, the left atrial body is the site of union between the appendage, the vestibule, and the septum. And the left atrial vestibule, which is smooth, merges directly with the body of the left atrium, which is also smooth. On the left, the pectinate muscles, which remain confined to the appendage, do not interpose between the appendage and the vestibule because of the smooth body. The coronary sinus is embryologically a left-sided structure, and it comes from the left sinus horn. And during development, the left sinus horn has walls that remain separate from the walls of the left atrium, and they become incorporated into the left half of the developing atrioventricular junction, becoming the coronary sinus.
So what we've seen now is that in the normal heart, there is indeed a major difference in the extent of the pectinate muscles relative to the vestibules. But we are talking about congenitally malformed hearts. And more importantly, we're talking about congenitally malformed hearts in the setting of so-called visceral heterotaxy. So the question we now have to ask is whether we can use this feature, the extent of the pectinate muscles, where we need it most in those patients who you will be describing as having visceral heterotaxy. And I can take you back to this study we did a long time ago now. It was done by Hideki Uemura, Japanese surgeon who came to work with me at Brompton Hospital in the early part of the 1990s and did some excellent work. But perhaps the most important piece of work he did was to collect together these 182 hearts from patients who had been diagnosed as having heterotaxy. And he specifically looked at the atrial chambers in these hearts. And he asked the question whether there were features within the atrial chambers that permitted him to describe them as being bilaterally morphologically left, bilaterally morphologically right. I said that the wrong way round. And the pictures that you're going to see very shortly are going to show you those hearts in which he considered that he could find evidence in which both of the atrial chambers exhibited the appearance of morphological rightness. We're going to show those in green. And the other hearts in which he felt both of the atrial chambers exhibited features of morphological leftness. We're going to show those in yellow. But when he started his study, he came across the situation that he was not always able to distinguish the appendages with certainty. And that was because he had started off by looking at the shape of the appendages. Now, I should tell you that when Hideki started this study, it was my belief that simply using shape, it was possible to distinguish between the morphologically right and morphologically left appendage. But Hideki looked at these 182 hearts, and in his opinion, it was not possible to use shape. You see in red there the large cohort of hearts in which, using shape as the arbiter, he was unable to say whether there was bilateral rightness or bilateral leftness. You see that in some of the hearts he could make distinction, but he could not make the distinction in all of them. And indeed, Richard van Praag himself pointed out that shape was changed by hemodynamics, and therefore shape was not an important feature to use as the arbiter of morphologically rightness or leftness. But Diane's also shown you already that there are differences in the junctions between the appendages and the remainder of the atrial chambers. So Hideki also looked at the junctions, taking note, presence or absence of the terminal crest. And when he did that, as you see, the number of hearts in which he was uncertain as to whether there was bilateral rightness, bilateral leftness, shrunk considerably, but it was still there. So by combining shape and junction, we still did not have a means with certainty of distinguishing bilateral rightness from bilateral leftness. But then Hideki came up with the means of distinguishing with certainty morphological rightness from morphological leftness. And that is what you have seen already, the extent of the pectinate muscles relative to the vestibules and the atrioventricular junctions.
This specimen has isomerism of the right atrial appendages, and we're looking at it in anatomic position, so how it was positioned in the chest so that the diaphragm is at the bottom of the screen. And that makes it easy for us to see that the apex of this heart was pointing to the left. The right-sided appendage shows us the blunt triangular tip and the broad junction with the venous component. So the superior cable vein on the right joined the roof of this right-sided atrium, and the inferior cable vein its floor. When I open the broad venous junction, we can see that there is a terminal crest or a prominent muscle bundle from which the pectinate muscles extend. You can see them around the entire anterior aspect of the appendage up here, and then looking as they extend around the right atrioventricular junction, they extend to the crux of the heart. This specimen has an atrioventricular septal defect, so that here we see the leading edge of the atrial septum. And I'd also like to point out that there is no coronary sinus. The appendage on the right has pectinate muscles extending around the entire right atrioventricular junction. So the constant component identifying a morphologically right atrium are those pectinate muscles around the atrioventricular junction. The appendage also has this broad junction with the venous component and a triangular tip. So on the right side, we have a morphologically right atrial appendage. On the left, we see the appendage with a very blunt triangular tip, and there is a broad junction with the venous component. Entering the roof of this left-sided atrium is a superior caval vein, and there were some hepatic veins joining the floor of this atrium. They've been cut away. The appendage, when we look inside, shows us pectinate muscles and a terminal crest, which has been partially incised with the rest of it on this aspect towards the left. And the pectinate muscles extend around the left atrioventricular junction to the crux of the heart. So on the left side, we have a pectinated appendage with a broad venous junction and a blunt triangular tip, so that pectinate muscles extending around the left atrioventricular junction confirm that we have a left-sided morphologically right atrial appendage. So this specimen has isomerism of the right atrial appendages with bilateral morphologically right atrial appendages. This specimen has isomerism of the left atrial appendages, and I'm showing it to you as it was positioned within the body so that the diaphragm is here. And this lets us know that the apex of this heart was pointing to the right. The left-sided atrium is tubular with scalloped crenellated edge, and it has a very narrow junction with the atrial vestibule. Entering the roof of this left-sided atrium is a superior caval vein with no identifiable terminal crest associated with the cavoatrial junction. And here is the inferior caval vein joining the floor of this atrium. Looking at the atrial vestibule, it is entirely smooth. There is the narrow attachment of our appendage, and the pectinate muscles are confined to the appendage. So this is a left-sided, morphologically left atrium. The specimen also has a common atrioventricular junction, and this is the leading edge of the atrial septum. The oval foramen is well formed and is in this area. The right-sided atrial appendage is also tubular with a narrow junction to the venous component. You can see that there is a superior caval vein entering its roof, and there is no identifiable terminal crest. The appendage has the pectinate muscles confined within it. There is its narrow junction with the atrial vestibule. This atrial vestibule is difficult to see the entire thing because the atrium is so small, but there is a smooth vestibule all the way around. The pulmonary veins also drain to this right-sided morphologically left atrium. So there are the left pulmonary veins and there are the right. So we have bilateral tubular or narrow appendages with a narrow junction to the atrial vestibules, pectinate muscles confined to the atrial appendages, and smooth atrial vestibules on both sides. So bilateral, morphologically left atrial appendages.
So what I hope you have seen is that when we use this feature, the extent of the pectinate muscles, then it is possible to distinguish, when you have the heart in your hands, the morphologically right and the morphologically left appendages. And that means if we have two atrial chambers, each chamber has its own appendage, there are only 4 possible patterns. So what are those patterns? Well, this is the usual pattern, cytosolitis, if you will. This is present in the overwhelming majority of patients you deal with having congenitally malformed hearts. And the essence of the usual atrial arrangement is what Diane has shown you already. The pectinate muscles on the right side encircle the vestibule and reach to the crux of the heart inferiorly. On the left side, pectinate muscles are confined within the tubular appendage, and the smooth vestibule is confluent with the smooth body, the smooth pulmonary venous component of the morphologically left atrium. And within that smooth left-sided vestibule, part of the left atrioventricular junction, behind that, we will find the coronary sinus. So that is the usual arrangement. You will not be surprised to know that in the mirror image arrangement, it is the opposite way around. And indeed, these two entities are isomers of each other, but in separate individuals. So in those individuals who have so-called situs inversus, it is not upside downness, as we've emphasized on so many times during these classrooms, it is mirror imagery. So the patients with mirror imagery have the pectinate muscles encircling the atrioventricular junction and the vestibule on the left side, and they have smooth vestibules confluent with smooth body, smooth pulmonary venous component on the right side. The coronary sinus will be right-sided, the pectinate muscles confined within the tubular appendage. But then, in our other two arrangements, we truly have isomerism. But it is isomerism of the atrial appendages. So in right isomerism, as you have seen, heart now, Diane has shown you, the pectinate muscles extend around the vestibules on both sides, and they meet at the crux. And significantly, when we have right isomerism, the coronary sinus is always absent. Left isomerism, in contrast, smooth vestibules are confluent with the smooth-walled body of the atrium on both sides, isomerism of the left atrial appendages. So you've seen, without question, that isomerism does exist in the heart. But here is the key: it is only the appendages that are truly isomeric. And this was a mistake we made in the past when we were trying to establish the presence of isomerism. Because when I first started speaking about this entity, I called it atrial isomerism. And that was a mistake, as Richard van Praag pointed out, as the patient with left atrial isomerism will be expected to have a pulmonary veins. Of course, that is a nonsense. So what we should have spoken about was isomerism of the atrial appendages. Equally important, we then need to recognize that isomerism of the appendages does not always correlate with the arrangement of the remaining bodily organs. And we knew that from the original study of Dr. Uemura. Because in that study, Dr. Uemura not only looked at the atrial chambers, he looked at the other organs that were available, and he showed us that the correlation with the bronchial tree was excellent, but not perfect. The correlation with the spleen, which at that time was used to segregate so-called heterotaxy, still done by some, was good, but far from perfect. So let's look at what Dr. Uemura found. So this is the bronchial morphology from those cases in his 182, in which he compared bronchial morphology with the finding of isomeric left appendages. And if there is left isomerism, since the left bronchus is long, you would expect bilaterally long bronchuses. You see that in 10% of the individuals, there he could not look at the bronchial tree, but in the other 90%, in 88% of those, indeed, both bronchuses were long, but in 2% of those, so essentially that was 2 individuals, there were lateralized bronchuses, despite the fact that the appendages were isomeric. It wasn't quite as good in the setting of isomeric right appendages. These are percentages again, so 10%, the bronchuses were not there. Comparison, in 11% of the hearts or the organs from patients known to have isomeric right appendages, 11% have lateralized bronchuses, either usual bronchuses or mirror-imaged bronchial arrangement. So pretty good, but not perfect. Much worse with the spleen. So if you have isomeric left appendages, left isomerism, the spleen is a left-sided structure. So if there is leftness on both sides of the body, you expect to find multiple spleens. Well, in a quarter of the individuals, Dr. Uemura didn't have access to the abdominal organs, so he didn't know what was going on in the spleen. But here are the proportions. So of the 75% in which he knew splenic morphology, 64% had multiple, 64% of the overall number had multiple spleens, but there you see of the overall number, 7% had a solitary spleen. Here is the key, 3% of these patients with left isomerism had absence of the spleen, whereas you expect to find absence of the spleen with right isomerism, and indeed in the majority of patients, the spleen was indeed absent. But as you see, 14% of those patients, there was a solitary spleen. This leads to the ridiculous situation in which you are forced to describe asplenia in presence of a spleen, and in 4%, multiple spleens. This doesn't mean that we should rule out the importance of splenic morphology or bronchial morphology. What it means is we should recognize the arrangement of the bronchial tree, the arrangement of the spleen is not always coexisting with the presence of isomeric right or isomeric left appendages. It is the recognition of the isomerism that is important in the heart. So what we've tried to show you today is that in the hearts obtained from patients who have so-called heterotaxy, the appendages are indeed isomeric. And that is important because it is the recognition of those isomeric appendages based, I emphasize again, based on the extent of pectinate muscles that sets the scene for sequential analysis. And that is why you have to start off with the recognition of isomerism of the atrial appendages. I stress again, just because you find isomerism of the atrial appendages, it doesn't mean that the rest of the individual is uniformly going to be isomeric. We must anticipate that in some cases there will be disharmony between the arrangement of the organs, but we cater for that simply by describing each set of organs in its own right. In the setting of so-called heterotaxy, nonetheless, when we look at the atrial appendages in terms of the heart, those who have cardiac malformations will show either isomeric right appendages or isomeric left appendages. And that is the bottom line for the introduction that you have seen today, because it is the recognition of those isomeric appendages, the starting point for sequential segmental analysis, that then sets the scene for identifying all those variables that you as clinicians need to identify before you can proceed to the appropriate treatment. Perhaps most importantly, the veno-atrial connections. The veno-atrial connections can be markedly abnormal, but you've seen in one of the hearts that Diane showed you today, some occasions, despite the presence of having isomeric atrial appendages, the venous connections, usual or case she showed you, they can produce mirror-imaged drainage. And that is something we will be stressing next week. She showed you hearts also that had abnormal junctional morphology. And both of the hearts she showed you with isomeric atrial appendages had common atrioventricular junctions. And this is something else next week we are going to be stressing the importance of recognizing what's going on at the atrioventricular junctions, also what's going on with ventricular morphology, because there are differences in the ventricular morphology between those having isomeric right appendages, those having isomeric left appendages. They are not absolute, but they are important, and we will discuss that with you next week, as we will discuss the difference in the ventricular arterial connections and so on. Because in the final analysis, we have to give a precise description of everything that is going on, but the starting point must be setting of heterotaxy to distinguish between those patients having isomeric right atrial appendages as opposed to those having isomeric left atrial appendages.
It was very good, Dr. Anderson, Dr. Diane. Thank you very much for this presentation. It was very clear, and we are looking forward for next week to see the differentiation of left and right. Dr. Silverman, do you want to start with your comments?
Good morning, and thank you very much, Bob and Diane, for a beautiful demonstration, very clear. There are a few interesting points about this from the point of view of an echocardiographer. And those are that it is sometimes difficult to recognize pectinate morphology on small echocardiograms, particularly in the fetus. But I do think that the contribution of the group in Atlanta, Georgia, for recognizing the terminal crest as a hallmark of the right atrial morphology is very valuable. So that when you find that there are two terminal crests, one in either atrium, you surely are dealing with right atrial isomerism. And I think that that has been very, very useful. Shape is another useful echocardiographic index, but as Diane had shown us so clearly in one of her morphological examples with the bifid atrial appendage, and indeed in all of the specimens, that although the appearances of the atriums are isomeric, they are not exactly mirror images as shown in the cartoons. And I think one has to be very careful about that. So I think that's the useful stuff that we can see. The other issue that I have is always to think of people not just as a heart specimen, but as total individuals. And I think that there are a number of systemic problems in isomerism that are very important and interesting to note and can present even later on in life. So let's first look at the babies that come in with extrahepatic biliary atresia, which is a feature. I don't know whether I'm going over what you're showing next week, Bob, but with extrahepatic biliary atresia is almost invariably associated with left isomerism, and it really affects the prognosis substantially. And lastly, that women that have left isomerism are often infertile because the incidence of bifid uterus is very much more common, and that's much more difficult to maintain a pregnancy with a bifid uterus. And I made a diagnosis in a 33-year-old who was presented initially at the infertility clinic, and it had some kind of a bizarre procedure in utero that nobody understood. That was indeed a patient with left isomerism. So I think that this is an ongoing story, and early in the Congenital Heart Academy lectures, there was a group that I think Bob and Gil Winoski presented on, and Gil had shown that You know, as far as specialties are concerned with looking at isomerism, it's extensive from psychologists all the way down to obstetricians and gynecologists. So it's a very broad spectrum of cardiac expression and extracardiac expression as well. So I think that's about all I really wanted to say about this. Thank you. Nice job, Bob and Diane.
Well, thank you for your comments, Norman, but it's clear already that old habits die hard, because you probably didn't even notice, but in your opening comments, you said right atrial isomerism. And as you know, we're not saying right atrial isomerism anymore. We're talking about isomerism of the atrial appendages. And so
that's it's a long mouthful, Bob, but it's a credit to you that you hammered that right atrial isomerism into me in my formative years.
Indeed,
and I've not been
have
able
to hammer it out again now. Very difficult.
In fact, I like to call it, when I think about it, rather than the mnemonic of using the spleens, I like to thinking of it as double left-sidedness and double right-sidedness.
Indeed, but again, only of the atrial appendages. But you made some important points. I mean, you commented on biliary atresia, and you are correct that biliary atresia is indeed a feature of left isomerism. But you are also well aware that in many instances, the patients who have biliary atresia do not have isomerism within the heart.
Correct.
So they have pulmonary isomerism, they tend to have interruption of the inferior cable vein. But when you look at the heart, the atrial appendages typically are usual. And so that's a very good example of where the patient can have bodily isomerism with the heart being normal.
Right.
So that is why we have to take account of each of the systems independently. And much of the controversy that currently continues to surround this issue is because people think we are saying that if you have isomerism, then it is an all or none phenomenon. And that is not the case. That is what we tried to demonstrate today, what we will try and emphasize again. Next week, each set of individual organs has to be analyzed in its own right. And the same then goes for the different parts of the heart, because what we're going to show you next week, even if you have isomeric right or isomeric left appendages, the venous drainage can be usual, or the venous drainage can be mirror imaged. But that does not rule out the fact that you can also have isomeric appendages. And that is why we stress today the importance of isomerism of the appendages. The point you made, Norman, nonetheless, the difficulty still in recognizing this with echocardiography. I recognize that fully. If you look at the questions and answers, you see that Paolo Zielinski, who also always asks very good questions, has made the comment that the coronary sinus is a morphologically left structure, and always the coronary sinus is absent in the setting of right isomerism. Paolo asks, does that mean the coronary sinus is duplicated in the setting of left isomerism? That is not the case. In fact, the caval veins, when they come back to the heart, are trying to be morphologically left, but they don't always succeed. In some instances with left isomerism, both of the caval veins are unroofed. So in left isomerism, also in some instances, you do not have a coronary sinus. And again, this is something we will discuss next week. Another question that has been asked, is the coronary sinus hypoplastic? It's not always coronary. Do you always have bilateral caval veins? And as you will be well aware, Norman, the presence or absence of bilateral caval veins does not distinguish between right and left isomerism. These are the features we're going to be trying to discuss next week. There is no uniformity within the overall group, except for the fact that you can segregate them on the presence of either bilateral left or bilateral right atrial appendages. And that is the take-home message for this week. And I think the two questions we've received thus far, I don't know if we've had any more thus far, Grace, but those questions emphasize that. Having identified the presence of the isomeric appendages, and in heterotaxy with cardiac malformations, always you will find isomeric appendages, so we can segregate visceral heterotaxy, excluding mirror imagery, into the subsets of right or left isomerism, depending on the morphology of the appendages. And that is our take-home message for this week.
Well, I want to make another little point which you should comment on, and that's bronchial morphology, because clinicians are like drowning men clutching at straws. They'll look for anything to make a diagnosis. And I think bronchial morphology is a very good indicator of whether you're dealing with isomerism or not. And it certainly helps to solidify the differential when you look at bronchial morphology. And I came across one of my colleagues, Dr. C.R. Patel from Akron Children's Hospital in Ohio, who has now been looking at the relationship between the distal pulmonary arteries and the bronchi to see whether the bronchi are ep or hyperarterial. And he can patiently wait to see, because in the fetus, the bronchial tree is filled with fluid, and this fluid can be Dopplered. So you can see where the bronchi are in relationship to the pulmonary arteries. And of course, if you've got bilateral eparterial bronchi, you're dealing with right isomerism, and if they're hyparterial, you're dealing with right isomerism. And he has some beautiful examples to show this in the fetus. So I don't think that this is something that you can necessarily relate to just looking at this afterbirth, but you can extend the bronchial pulmonary relationships even further into uterine life to help make the diagnosis. And
Indeed.
As a clinician, there's one other point that's very important, is that in one's mind, one usually looks for the segregation of the various things. But when you deal with something and you say that there is perhaps isomerism, then what you need to do is to start looking at all the various things. So look at the pulmonary bronchial relationships, at the position of the spleen, the bronchi themselves, the azygous connection with the interrupted inferior vena cava. Look for hepatic veins that drain, as Diane showed so beautifully, in the one heart directly into the atrium, and so on. And so it helps you when you start thinking, may I be dealing with isomerism, that you can segregate all of the other important features of the expression of these genetic abnormalities together.
Indeed. I mean, you make, again, very important point. The only caveat of that is that if you find bilateral morphological left bronchuses, that doesn't always mean you're going to have isomeric left appendages. But I think probably in 95% of cases, you will have concordance between the bronchial anatomy, the appendage morphology, much less good with the spleen. But you're entirely correct. And these are the things that are going to point you in the right direction. But you have to be aware that on occasion, there will be the exceptions that test the rule. And that's why we have to come back again. In the final analysis, it is the appendages within the heart that distinguish between left and right isomerism.
So I want to make one further ultrasound point to this group, and that's in my experience with echocardiography, particularly when you do transesophageal echocardiography. One of the valuable ways in which you can examine the heart is to put the probe into the stomach and look at the heart from the stomach area, and you can see really almost the same as the costal images that you can see, because indeed you are subcostal, but much deeper. Now, when you deal with isomerism, because there is heterotaxy of the organs, when you place the probe in the stomach, the heart disappears because the heart is on the other side. And so that becomes very frustrating and makes transesophageal echo in isomerism much, much more difficult. That's all I wanted to say.
And I mean, we have Diane with us. Diane, you do autopsies all the time now. You do lots of fetal autopsies. What's your take on what we've discussed thus far? You're muted at the moment. There we go.
I do have cases where the bronchial morphology does not match, and I have one case of isomerism of the left atrial appendages that has no spleen. I haven't seen many fetal cases of isomerism. I have seen one fetal case that was a dilation evacuation that had multiple spleens as its continuation of the inferior cable vein and a normal heart. So not many fetal cases I've seen at autopsy though.
As we were preparing for next week, however, you did, because in the hearts that I've seen, most of the hearts that I've seen with left isomerism had symmetrical pulmonary veins, two on each side. But you commented to me that in the hearts that you have seen recently, either all the pulmonary veins have been coming to the right-sided atrium or the left-sided atrium. Is that not correct?
Yes. The fetal case that I've used in the several presentations with the bilateral left appendages has quasi-mirror image venous drainage with pulmonary veins to the right-sided atrium and cable veins and hepatic veins to the left-sided atrium. And I have another case that has normal pulmonary venous drainage to the left atrium, aside from partial anomalous venous return of the right upper pulmonary vein to the superior cable vein and partial anomalous venous return of the left upper pulmonary vein to the coronary sinus. Those are the only two isomerism of the left atrial appendage cases that I have available.
And this simply goes to point out again, that the starting point has to be the atrial appendages so as to determine cardiac arrangement.
And actually, the heart that I said has the partial anomalous pulmonary venous connections, that heart is fairly normal looking. It has right-hand ventricular topology, concordant ventricular arterial connections with a VSD that's healed by the tricuspid valve with some posterior deviation of the outlet septum and a coarctation. So otherwise, if someone didn't know that they were looking for isomerism of the left atrial appendages, they might call this a normal heart because the right-sided appendage is quite dilated hemodynamically, and it could be easily confused with a right appendage if you weren't sure of what you're looking at.
But you're going to show us that heart in next week's presentation, are you not? You're going to make
it. And that case does not have a spleen either. But it has interruption of the hepatic portion of the cable veins.
But as you and I also discussed, it's very difficult for you to show everybody else absence of the spleen.
I can show you the stomach. You have to believe that I didn't remove it, but.
Yes.
So Grace, have we exhausted the questions? Have we satisfied everybody this week?
We have two more questions, and let's see if you're able to answer them. So Camilo is asking, in the case of single atrium, what would be the key to identify its morphology?
Well, there's no such thing as a single atrium. I think what he's talking about is a common atrium. I've never seen a heart with a single atrium. I've seen lots of hearts with common atrial chambers because of absence of the atrial septum. And in many ways, he's answered the question himself, because the common atrium is when you have the combination of the two atrial chambers, and the key to differentiate them is the arrangement of the atrial appendages. You can have a common atrium with usual atrial arrangement. You can have a common atrium with mirror imaged arrangement. Much more frequently, however, if you have a common atrium, there is likely to be either isomerism of the right atrial appendages or isomerism of the left atrial appendages.
We have one last question asking, heterotaxy, as defined earlier, covers both left and right isomerism. They have always been associated with multiple congenital anomalies and carry a worse prognosis with or without surgery. Most of them will be physiological single ventricle situation. The only difference between heterotaxy and isomerism is that mirror image does not find a place in heterotaxy.
With the definition as currently offered by the International Nomenclature Committee, that is the case. But I don't think that should be the case. I wrote a review of that 4 or 5 years ago. Diane was involved with me on that. And one of the criticisms of the review, when we suggested that heterotaxy should only include the isomeric forms, the person reviewing it was not a cardiologist. The person reviewing it was a pediatrician, I think. And the pediatrician said to me, heterotaxy is anything other than the usual. So mirror imagery for him or her, whoever the reviewer was, for him or her, heterotaxy included mirror imagery. And as I pointed out at the starting point of my presentation today, in fact, within the definitions offered by the Nomenclature Committee, there is no reason to exclude mirror imagery from the category of heterotaxy. And so I would now press very strongly for heterotaxy to include mirror imagery, right isomerism, left isomerism, which can be distinguished on the basis of the arrangement of the atrial appendages. But that is something we're going to have to discuss further. We have a meeting, in fact, of the Nomenclature Committee, a virtual meeting at the end of June. And this is one of the things that we will be discussing.
Great. Please let us know the outcome of this meeting.
Indeed, it clashes, in fact, with the last meeting of the Congenital Heart Academy. So the Nomenclature Committee know that I'm not going to be able to join them until we have finished the meeting of the Congenital Heart Academy. So that will be on the 25th of June.
Okay, perfect. So we have one last question from Mateo Rios. In a patient with left isomerism, it could be expected to have two superior vena cava. But there are some cases that there's not such anomaly. Oh, it's the same question. So yeah. we answered this one already. So it just appeared again.
In fact, I don't think you should say expected to have two caval veins. I think the presence or absence of the caval veins is one of the features that you need to look for and exclude. I mean, Norman, would you always expect to find dual caval veins in the setting of isomerism?
Usually. I don't think always, but usually you do. Oh, I'm not muted.
Yeah, you are. You're there, yeah.
Yeah, I think it's usual, but it's not always exclusive. Like almost everything in isomerism, it's common, but not the rule.
And so it's something you would expect to find it, but you would not be surprised.
No.
And so then you would want to know, is the caval vein right-sided or is the caval vein left-sided?
Sure.
But the one thing we can rule out is that if you have right isomerism, there will never be a coronary sinus.
That is correct, Bob. I have never seen a coronary sinus in right isomerism.
And we have to make the caveat there is that you can have asplenia with a coronary sinus, but correct. That would then be asplenia in the setting of left isomerism, or, as sometimes happens, asplenia in the setting of a usual heart or a mirror imaged heart.
Exactly. Yes, we've sort of skirted that new paper that came out 2 years ago in the Journal of Cardiovascular Imaging, I think circulation, by the group from Toronto, where they looked at all of these issues and found exactly what Hideki had said and restated it, that there is no golden rule in isomerism. You can get, but the atrial appendages are the important issue.
Indeed.
There's one other issue about ultrasound that is important, is that you mentioned this, Bob, but I've noticed this, that in left isomerism, when you look at the LSVC connection to the atrium, there's usually a tag of tissue on the superior aspect, which is probably the remnant of a coronary sinus septal defect.
Absolutely. And that is the whole point. When you have left isomerism, the caval vein, and this is what Diane, I hope, is going to be able to show next week. I've asked next week, but when Diane shows the features of left versus right isomerism, we're going to look at how the caval veins come into the atrial chambers. And in right isomerism, they come in relative to a terminal crest. If they're bilateral, there are bilateral terminal crests. If there is left isomerism, if there are bilateral caval veins in the setting of left isomerism, they are both trying to be unroofed coronary sinuses. And the point you make there is a very good one.
So the one last point I want to make, and that's a Congenital Heart Academy commercial, because if you go back in the Congenital Heart Academy, in the fetal series that Dr. Bada is discussing, there is a whole section on fetal isomerism and its recognition by me on the Congenital Heart Academy. So there are other series, I think Bob has done and Diane have done other series of isomerisms before as well. And it's always good to review all of this information to augment your own knowledge of these things.
Very nice, Dr. Silverman. Okay, Dr.
Thank you.
I have just a question, a comment and a question. I would just say, first of all, that, you know, the understanding the nuances of the atrial appendages and both in the atriums themselves and isomerism is really important as we try to do biventricular reconstructions of a variety of these situations. And I think this has just been great to understand at this level. But one question I have for you is to get back to what you were just mentioning in terms of heterotaxy, including situs inversus as well as isomeric cases. You know, there's a big difference between situs inversus in terms of clinical outcomes and isomerism. And just about in every stat category is an increased risk of mortality, both of mortality and morbidity, with isomeric cases versus situs inversus. So I think that's another differentiator, I think, in terms of risk. You know, there's a lot of physiology that's not normal, looking at ciliary function and things in isomeric patients, which I'm not aware is in situs inversus patients. I may not be correct there, but it just seems to me that isomeric patients add a level of complexity and risk above and beyond just situs inversus.
I think you are 100% correct there, but by the same token, would you not also agree that right isomerism carries an amount of risk that greatly outweighs that for left isomerism? So the point you're making is that we should distinguish mirror imagery, situs inversus, from right isomerism, left isomerism. So maybe then we should just continue to have heterotaxy as separate from mirror imagery. But then I would extend your comments still further to say that heterotaxy itself then should be separated into left isomerism versus right isomerism for the very point you've made, that the risk must be appreciably better for you as a surgeon if you're dealing with a patient who has right isomerism compared to a patient who has left isomerism.
Agreed.
Do I see that you've got a beard?
It's nascent, yes.
Has this anything to do with COVID, or is it?
It looks good. It looks excellent. Perhaps in reflecting on the philosophy of isomerism, it might be that with all of the genetic issues that are involved, that perhaps when we understand the genetics, we will find that even isomerism is not a single gene entity, but that there are multiple genes that are involved in making this whole syndrome up that we've described.
Absolutely. And the point you make there, Norman, is we're never going to segregate those genes unless we start looking at each case individually. So, for example, if we have patients who have isomeric left bronchuses but normal hearts, we should be analyzing the genetic makeup of those differently from the overall set of left isomerism when we have left appendages and left bronchial isomerism. And until we start analyzing each system of organs and comparing and contrasting the individuals with the different makeups, we're never going to get to the bottom. We're never going to make the distinctions, which, as you say, are so crucial. And it must be feasible now. I mean, we can do genomes, can't we? We can do genomic analysis. So now if we know that a patient, for example, the patient we know has biliary atresia, isomeric left bronchuses, azygous return of the inferior caval vein, yet usual atrial arrangement, we must be able to collect a series of those and look at their genome versus the more regular type of left isomerism with congenital heart disease.
Sure.
But until we start distinguishing and describing what, at the moment, when everything is put into the bucket of visceral heterotaxy, we've got all our arms tied behind our backs.
Sure. Maybe
Very
one
nice,
last
guys.
point
Okay.
following Dr. Q's description. I think that mirror imagery is a rare disease. And looking at my archive of echocardiograms of mirror imagery, I was able to come up with 3. But in some so-called mirror imagery, when you look at it and you go through, so many of them are actually isomeric. And I think isomerism is a lot more common. And the question of benignity of left isomerism is somewhat overinflated, because if you look at the fetus, for example, the diseases that you find in the fetus with left isomerism, including congenital heart block and the so-called condition that you don't like to express, hypertrabeculation syndrome, or spongy myocardium, as it's sometimes known, is much, much more common in the fetus. And a fetus with an AV valve problem, with a spongy myocardium that can't work very well, and with heart block, is destined to not be survivable. And so that if you look at the at what happens with the fetal isomerism, a lot of those fetal patients actually never make it to birth. They die in utero. Indeed,
but then they are not going to be a problem for the surgeon, are they?
So well, that's right. The right isomerism is a much bigger nightmare for the surgeons than left isomerism.
Yes, we have to build it. But I think it makes the point of understanding all the variability and understanding what each patient really has and the complexity of that situation and what would be the reconstruction. That really determines ultimate risk. And you have to take each individual as the components themselves to assess that.
Right.
Okay, for the attendees, I place on the chat box the link for the Congenital Heart Academy talks about heterotaxy and isomerism. If you want to take a look, we have a big webinar. We had Mary Cohen talking about eco features of isomerism. So if you want to take a look, it's in the chat box. And thank you very much, guys. It was very good as usual. Looking forward for next week to see the continuation of this topic.
See you Monday, Grace.
See you Monday for sure. See you Saturday for Dr. Gil Vernovsky, hypoplastic left heart syndrome, and see you Monday with Dr. Silverman. Thank you, guys. Bye-bye.
Bye-bye.